And you're just seeing my first slide now.
Hey, everyone. Thanks for joining the EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU provider, physician at Hopkins. I am a member of Pikesville Volunteer Fire Company in Baltimore County and have the honor of serving as one of the Associate Medical Director's Office for Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the Medical Director's Office, on behalf of the EMS Office, Chief Nats, EMS Training Academy staff, and Captain Lenny Stewart, thank you for what you guys do every day, and thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, who is a young member and volunteer at Pikesville, Baltimore County. Ashley is helping us with the live stream and the Zoom platform, as well as for the CMEs. Ashley, towards the end of the presentation, will put a link in the chat. Click on the link, enter some information, and get your MIMS CEUs. If you have questions about your MIMS CEUs, any difficulty at all with the link and signing up for training tonight, please make sure that you stay on after Linda's presentation, and we are happy to help you make sure that we get your MIMS CEUs. Any concerns with signing in need to be resolved tonight before we end our training. I won't be able to accept an email tomorrow, for example, sharing that you had some difficulty for tonight. I'm so sorry, but thanks for joining us, and super excited tonight to have with us again Linda Toral. Linda did a couple of presentations for us so far that are available on the EMS Academy YouTube site. Linda is a stroke certified registered nurse and certified neuroscience registered nurse with over 35 years of experience. She graduated from the University of Delaware, where she volunteered on the student ambulance, City of Newark Ambulance, and the Newark Emergency Room. She began her postgraduate career at the University of Maryland Shock Trauma Center in the neuro-trauma unit. Her love for trauma and emergency nursing then took her to the emergency room at Franklin Square Hospital. She has been with Sinai Hospital since 2000, holding various positions to include outpatient clinic manager, stroke unit case manager, stroke program coordinator, and her current role of manager of the Manager-NeuroRescue Network at LifeBridge Health. She has participated as an invited speaker in stroke certification review courses and the Maryland Comprehensive Stroke Conference. She has also published on stroke recognition using the BEFAST tool and presented research during a poster presentation at the International Stroke Conference. Linda, thank you so much for all the work that you're doing with sharing information, and thanks for being here to help support our EMS providers. We super appreciate you.
Thank you very much for having me. If you're ready, we can get started. This presentation tonight will be on posterior circulation stroke and some atypical presentations. And just full disclosure about the title of the slide, atypical presentations is really the perception from the community and maybe newer providers and even some medical staff. The neurology providers and team members don't see it as atypical because we recognize it as what you would normally see in posterior stroke presentation. But because posterior stroke is more rare than your anterior circulation strokes, the symptoms are not recognized as easily by the public and even by some medical providers. So therefore, the choice to provide this education and help us all care for patients, to the best of our ability. So thank you all very much for joining me tonight for this. Okay, the objectives tonight are just to recognize the 5 Ds of posterior circulation stroke, as well as the 3 Ns. Mention 1 assessment tool that may be used to help identify posterior circulation stroke, and state 3 physical findings you may note in the posterior stroke patient. Just a little introduction as we get started here. In the United States, about 800,000 people will experience a stroke annually. 610,000 of those are first strokes. Even though there has been an enormous amount of education and work done with communities regarding identification of risk factors and management of weight, diet, nutrition, exercise, etc. Stroke is still the leading cause of death and long-term disability. About 80 to 87% of all strokes are ischemic, and 20 to 25% of ischemic strokes occur in the posterior circulation. 20% of cerebral blood flow is attributed to the vertebrobasilar or posterior circulation. And you can see from this diagram here with the circle of Willis, so up here, which is not in the blue square, is your anterior circulation vessels, the arteries that feed that area. And here is your posterior circulation. So you'll note the two vertebral arteries that join to form the basilar artery, and then that splits off into two posterior cerebral arteries. There certainly are smaller little pontine perforators in here and other small vessels coming off. But as you can see, these are two very large main arteries in here. Again, just a little bit of review for posterior circulation stroke and the areas of the brain that are fed by the vessels we were just speaking about. Some patients have blood supply from the posterior cerebral artery that feeds into the medial temporal and parietal lobes. The posterior cerebral artery also feeds the thalamus and the occipital lobe. And then the brainstem, which the midbrain pons and medulla make up, is fed by the basilar artery, as well as some other smaller arteries. And the cerebellum, again, fed by the superior, anterior, inferior, and posterior inferior cerebellar arteries. Definitely a mouthful, but as you can see, it's kind of critical that we understand how the vessels are, the blood flow is feeding into this area so that we can see the areas that will be damaged and the deficits that will be observed when these areas are affected. So the etiology of posterior circulation stroke, as in anterior circulation stroke, common causes are atherosclerosis. That is the most common disease of the posterior circulation arteries, vertebral and basilar arteries. In this area, as you noted, with those vessels, thrombosis can lead to a complete occlusion. So imagine a thrombosis in the basilar artery that could then go on to completely occlude that artery. Certainly when you add some stenosis to a thrombus in that area, it's kind of a recipe for disaster. Cardioembolic sources also account for about 20 to 30% of infarcts, as well as dissection, which could be either traumatic or spontaneous. In the pre-hospital field, you might be more familiar with their traumatic dissections that you recognize from motor vehicle accidents, patients with acceleration, deceleration, injuries, those wearing seatbelts. It can also occur from like contact sports, football, lacrosse, etc. Less commonly, it may be due to migraine, hypercoagulable disorders, drug abuse, vasculitis, and fibromuscular dysplasia. So starting with some pre-hospital challenges, up to 70% of people having a stroke access EMS. In a 2021 publication in the New England Journal of Medicine, they identified characteristics of acute stroke presentations where there was an inaccurate identification by EMS. While they were analyzing the studies, there were 21 of them, they found that 26% of all the stroke presentations via EMS were not recognized in the pre-hospital setting. Most of these common presentations included posterior stroke symptoms. So you can see why it's so important to recognize these symptoms. And those symptoms in this cohort were nausea, vomiting, dizziness, and some type of visual disturbance. Nausea and vomiting occurs in about 20% of all stroke patients, but most often in those who have a stroke in the vertebral basilar area. Dizziness, which is most common in cerebellar stroke, occurs in up to 75% of patients. But when it's attributed to stroke, it's usually accompanied by other symptoms, which is why you'll hear a little bit later how we have worked with the emergency department to identify these other symptoms and how we look at patients who present with dizziness and really hone in on not only the dizziness, but what we call dizzy plus. What is the patient presenting with in addition to the dizziness? So pre-hospital setting is not the only area with stroke challenges. The ED has challenges also. As many as 165,000 strokes per year may be misdiagnosed in the emergency department. Posterior circulation strokes especially have more vague symptoms, and often those symptoms are attributed to other causes. They are twice as likely to be misdiagnosed than anterior circulation strokes, and one population-based registry showed that 90% of TIAs that had posterior symptoms went without recognition. And the way they were looking at this was patients that presented to the emergency department with varying degrees of posterior circulation TIA symptoms. So they had the symptoms and they either resolved very soon after arrival in the ED or they resolved before even arrival in the ED, but they were reporting those symptoms. The patients went home and usually within 30 days they had a readmission. So that's how they were capturing those patients. Traditional stroke symptoms like hemiplegia, are rarely missed, but these non-traditional stroke symptoms increase the odds of misdiagnosis 43-fold. And then this misdiagnosis leads to a worse clinical outcome because the patient's stroke extends, they may have brainstem compression, we were looking at that, basilar artery area, and they then can go on to have a recurrent stroke because there's no secondary prevention going on, they're not receiving an aspirin, et cetera, if this delay is occurring. So especially in posterior stroke, we see this underdiagnosis. 47% of people having a posterior circulation stroke experience dizziness as their primary symptom. So these are the people coming into the emergency room with, I'm dizzy, I'm off balance, I'm woozy, all different terminology for dizzy. And around 4.4 million people visit the emergency department every year with this complaint, vertigo, dizziness, etc. And of those 4.4 million, strokes are the cause only 3 to 5% of the time. So a really small subset of this population. So imagine all the ED providers that are being challenged by this influx of dizzy people who then they have to determine, is this dizzy because of flu? Is it dizzy because of dehydration? What's the dizzy due to? So for years, physicians have been asking for a better algorithm or way to assess their patients so that they can really rule out the central or stroke type syndromes from the more peripheral symptoms. So there is an exam that the providers use called the HINTS exam, and when they combine that with a thorough history, it helps them to better diagnose and triage these patients. with that history, they want to make sure they're getting, you know, a history of an onset. Was this an abrupt onset? Did this occur over, you know, days, weeks, months? And if there are any triggers that are involved as well. This exam is called the HINTS exam, and it's used to distinguish stroke from these more peripheral symptoms. And I am going to share a very short video with you. Are we seeing the video? I hope.
Yes, we can see it.
Yep, it's perfect.
Great, thank you, everybody. So here we're seeing nystagmus. It can be vertical, torsional, or direction changing. You can just watch. So they'll combine that with the head impulse test. And this is a normal head impulse test. You can see how the eyes are focused as the head moves. So they're not pinning their eyes to the right or the left. They're, you know, keeping their eyes on whatever they're focusing on while their head moves. And then finally, this is a test of skew. And you can see that the eyes, when they take the ball away, are going in different direction. They're lagging. So there's down and a deviation. So someone who has the nystagmus, a normal head impulse test, and then the skew deviation would be considered positive for stroke. And again, this is in no way am I suggesting that this be used in the pre-hospital setting, but this is something that assists the providers in the emergency department to help in their triage of the patient. Okay, back to the PowerPoint. Okay, so some factors that lead to the delay in recognition of posterior circulation stroke. We know that recognizing the symptoms can be challenging. There are various areas of the brain tissue, as you saw, that are supplied by the posterior circulation, and you often have a wide range of nonspecific symptoms. The differences just individually in a patient's anatomy may also lead to some varied presentations. Sometimes patients just have a normal abnormality. They also may have collateral circulation as they have aged, and that can lead to some varied presentations. We also know that pre-hospital and ED assessment scales often do not adequately capture the signs and symptoms of posterior circulation stroke. They are usually all some form of a FAST or Cincinnati pre-hospital stroke scale. And these are very heavily weighted to anterior circulation stroke. Posterior circulation infarcts may also be missed by imaging. The gold standard when we see an acute stroke in the emergency department is to do a non-contrast head CT. And we do that to look for blood so we know, is it safe to administer TPA or alteplase to these patients. But a non-contrast head CT is not the best imaging for a posterior circulation stroke. We much prefer a diagnostic angiogram, CTA, or MRA in those cases. So if we break down a posterior circulation stroke into the two largest vessels, basilar artery and vertebral arteries, starting with the basilar artery, this makes up only 1 to 4% of all ischemic strokes. The strokes in the basilar artery can be caused, as we said, by thromboembolism, atherosclerosis, or dissection, which can be due to trauma, as well as chiropractic manipulation, and even actually visits to the hair salon. If anybody has ever had the experience of transporting an elderly lady who has had her hair done at the salon and had her head kind of cranked back in one of those sinks to get her hair washed, it does happen that way also. But due to the variety of symptoms, some of which can be vague, basilar artery occlusions can be difficult to diagnose. And as we said, some patients with widespread collaterals can exhibit some mild or transient symptoms. But if left untreated, a basilar artery occlusion has up to a 90% mortality rate. However, it has been noted that in those patients who have been recanalized, so taken to IR, you could reduce that mortality to as low as 40%. If you recall from previous talks that I have provided, at least, the mechanical thrombectomy studies that were done, DAWN, Diffuse 3, that were really seminal in opening up the window, extending the window of intervention for patients, they were based on posterior circulation arteries. They were based on anterior circulation vessels, not posterior circulation. So there's definitely a lack of, up until this point, studies and recommendations that could be extrapolated to those posterior circulation stroke patients. Because it worked in the anterior circulation, we don't know that it will work in the posterior circulation. But we do know that these basilar artery occlusions usually present in one of three ways with a different kind of constellation and onset of symptoms. It can be a rapid onset of motor and bulbar symptoms, and those would be like a facial palsy, dysarthria, dysphagia, some dysphonia, and then a decreased level of consciousness. The hallmark sign for a basilar artery occlusion is either a very decreased level of consciousness or entire loss of consciousness, and then focal motor weakness. But there can be varying degrees of, hemiparesis or quadriparesis. The patient may also have subtle or stuttering symptoms that have occurred over a few days that then progress and end with these disabling motor and bulbar symptoms, a decreased level of consciousness, or both. And then finally, there just may be some early kind of non-specific symptoms that patients may exhibit, which would include headache, neck pain, loss of vision or visual changes, some diplopia. They could have dizziness, again, some paresthesias, dysarthria, ataxia, and even some tonic-clonic movements. They may even have episodes of hemiparesis that then that resolve, but then move on to become permanent. Probably the worst outcome of a basilar artery occlusion, and when I say worse, I mean even worse than death, is locked-in syndrome. This is a syndrome that results from damage to the brainstem, specifically in the area of the pons, because that's where the neuronal pathways between the cerebrum, spinal cord, and cerebellum flow. So an occlusion there would interrupt the motor fibers from the brain to spinal cord and those in the brainstem, which control facial movement and speaking. And I'll go on to detail a little bit more about what this really means, but I just wanted to mention this book that was written by somebody who did suffer a massive brainstem stroke. And this book was written by a French journalist who, after his stroke, he used his one functioning left eyelid to basically dictate this book to somebody to detail what his journey was like. And he likened it to being buried alive. So he and people who have this symptom or syndrome are awake and conscious. Their cognition is entirely intact. I mean, he wrote a book, so he dictated a book. They are able to feel pain, but they're unable to communicate except for usually eye movements and blinking. They don't have other voluntary movements usually. However, because once again, back to varying degrees of collaterals or the way different vessels may be in an individual person, they may have some other function, but it's usually very minimal. They may retain some other eye movements, have a horizontal gaze, may have some facial expression, limb, head, or tongue movements. I believe this journalist eventually was able to move his head a little bit, but not much more than that. At one time, this was thought entirely irreversible. Some people are able to regain some function over time. And of course, over time, we have come up with other mechanisms of communication that may not have existed, decades ago. Certainly decades ago, if someone were to have a vascular stroke, they just would have died. But now with the opportunity of intervention, whether it be IVTPA and or neurointervention, we are able to potentially open up and restore circulation earlier and potentially decrease their deficits. But overall, a minority of people have a good recovery in these situations, and most are severely impaired if we cannot restore circulation. For vertebral artery embolus, one study in the New England Medical Center Posterior Circulation Registry was the largest registry capturing data from, I believe, around 2,000 patients, noted that 40% of posterior circulation strokes are due to emboli, half of which would be cardioembolism and the other half atherosclerosis. It does tend to occur more often in men, and you'll see the difference as we talk a little bit later on about another syndrome that occurs more often in women, but this one occurs more often in men and also in patients that have other stroke vascular risk factors such as peripheral artery disease and coronary artery disease. For vertebral artery dissections, these typically occur in younger patients. We talked a little bit earlier about, contact sports, maybe some, motor vehicle accidents, and it, does account for up to 25% of strokes in the young. It's usually associated with some form of trauma or neck manipulation, and patients may present with a headache or neck pain. They can have a pseudoaneurysm that would form if the dissection extended intracranially, which can then increase the risk of subarachnoid hemorrhages. So a delay in acute treatment is due to many causes, but the biggest being lack of recognition. So we know that emergency department nurses rely heavily on EMS and their notification, and also just the report that's coming from EMS. When EMS comes in and says, this is what I have, or they call in with a stroke alert, nurses and, ED staff rely heavily on their impressions. Data on posterior circulation stroke versus anterior circulation stroke has shown that there is a prolonged ED doc evaluation to neurology consult time in this population, which then lead to prolonged door-to-needle time. However, the neurologist to needle time was similar in both groups, and that just speaks to the fact that neurologists know what they're looking at, know what they're looking for, and know immediately that these are posterior circulation stroke symptoms. So once they're consulted, their time to treatment is going to be the same as they would in an anterior circulation stroke. it was noted that the presence of nausea and vomiting was associated with even a longer time from emergency department evaluation to neurology evaluation, and then had a significant association with delayed treatment. So throwing it out there, why would adding nausea and vomiting to somebody's complaints of dizziness or other posterior circulations delay treatment any further? Does anybody have any idea why that might happen?
Feel free to put your thoughts in the chat, you guys.
I'll give you a minute, and that way, if Sean has some responses, we can.
So folks are
thoughts.
typing in thoughts of cardiac etiology. It would mimic the flu.
Okay, yeah, absolutely. Thanks, great, good responses. That's right. You're just I don't want to say you're complicating things, but what you're doing is you're then expanding their differential. So you add nausea and vomiting, and that has now blown up what this could be, right? The flu, cardiac stuff. So exactly why. But it's definitely an interesting observation, and certainly a delay in treatment that would be attributed to this. So, again, just to throw out a slide with all of the constellation of symptoms that you may be seeing or hearing as complaints from a patient. With vertebrobasilar circulation, you're going to see everything from hiccups. I don't know if anybody has seen somebody who's had, a stroke that, what they're noticing is hiccups. And these are nonstop hiccups. Can't sleep, can't eat, can't even catch your breath type of hiccups. They just don't go away. There's, nystagmus. They could have double vision. Again, the nausea and vomiting, as well as complaints of dizziness or vertigo, being off balance, ataxia, the dysarthria, as we talked about, and dysphagia. And the dysphagia doesn't have to be so obvious that someone is actually drooling. Sometimes it's not even noticed, except when someone tries to drink or eat and they choke. And they're choking, or their eyes are tearing, silent aspiration. So any of these symptoms and, combination of them can be occurring in somebody having a posterior circulation stroke.
Can you
And
talk
you'll notice, yes, go ahead.
Yeah, I just want to make sure before we move on, the ipsilateral Horner's, homogenous hemianopsia, dysmetria.
Yep.
Yeah, if we could describe.
Yeah, sure. And if also please notice that somebody can have contralateral hemiparesis or hemiplegia. This can be symptoms that are mimicking, now in this case, an anterior circulation stroke, right? So then it's probably going to be a little bit more obvious, but we're talking about dysmetria. How would you identify that? We're going to get into that a little bit further on, but that goes along with ataxia and, people being clumsy, their cranial nerve palsies. You might see some, gaze deviation. And again, the impaired level of consciousness, drooping eyelid. So you're having crossed body with sensory and motor function. So a lot of, posterior circulation symptoms in here. And certainly you're not going to have every one of them, and you're possibly going to have some combination, but it really will depend upon where that occlusion is occurring or where that damage is.
And can you go back for a second?
Yes.
And Horner syndrome is just a droopy eye, right?
Right. A droopy eye and pupil, and it can be a little bit of a like facial droop too.
What about the hemianopsia?
Hemianopsia is your vision, your visual field. So loss of one side of your visual field.
Thanks.
Okay. And then your, so our posterior circulation strokes, this is where we talked about how difficult it is when someone comes in and says, I'm dizzy. So what we've encouraged our providers to do is to dig a little deeper and find out if truly they are just dizzy, or just how are they call it, vertiginous, etc. Or if there really is something else going on. So dizzy plus something else is bothering them, and we call this dizzy plus. And this is the 5 Ds we talked about. When they present with the usual complaint of I'm dizzy, you really want to get into those clarifying questions to determine if they have additional symptoms. So the 5 Ds attributed to posterior circulation stroke, which we've already mentioned in the constellation of symptoms, but to narrow it down into 5 Ds, would be the dizziness, which can be described, again, very vaguely, lightheadedness, vertigo, diplopia, so that would be double vision, but it can be, blurry vision, loss of vision, dysarthria, so you're going to listen for slurred speech, dysphagia, so again, we talked about that trouble swallowing, if they can notice that, but it may be as simple as a lot of coughing, some choking, and really it could even just be tearing, eye tearing, or eye watering when they're eating or swallowing, as well as dysmetria, which includes ataxia. So this would be a person, and we'll talk about this in a little more detail, who's having kind of a wide-based gait, or they're off balance, or they find that they're potentially kind of running into things. For dysmetria, we'll talk also a little bit later about an easy test for this, but it's simple for the providers to just do a finger to nose. They call it pass pointing. So you ask the patient to touch their nose and then to try to touch your finger. So you're reaching out, they're reaching out, and you're holding your finger out for them to touch it. And then as you move your finger, you're getting them to touch their nose to your finger. And what you'll see is for somebody who's not having any issues, they can touch your finger. For somebody who is, they're either going to kind of wobble when they move to touch your finger, or they're going to go to touch you, but they're going to go past you or alongside of you. So they're not going to be able to kind of hone in on where your finger is. And again, we have to remember that patients with posterior circulation stroke may also have some of those anterior circulation motor sensory hemiparesis type symptoms. So I just want to take a couple seconds quickly to differentiate dysarthria from aphasia, and the difference between slurred speech and actually a language problem. So dysarthria is a motor speech problem. This is that slurred, garbled speech. It kind of sounds like people have marbles in their mouth. And this results from a weakness of the facial muscles, the tongue, throat muscles. The common causes would be stroke, brain injury, brain tumors. It may occur in multiple sclerosis, as well as Parkinson's disease. Aphasia, on the other hand, is a language problem. So this is when the language area of the brain, usually in the left hemisphere, is involved. And you will find people have just nonsensical words in response to a question, or they just may be speaking, trying to communicate with you, and it's making no sense at all. They may have trouble expressing themselves, have word finding difficulties, or in some cases, they may be mute entirely. So you'll ask them something and there is no response whatsoever. And like I said, this results from damage to the language areas of the brain, usually in most people in the left hemisphere and anteriorly. And common causes of aphasia would be, again, stroke, brain injury, brain tumors, and migraines may even make it happen, as well as seizures. So ataxia, which when we put it under the 5 Ds, we put it down under dysmetria, is just abnormal, uncoordinated movements. It may affect the hands, the arms, the legs, and is likely a result in the case of posterior circulation stroke of cerebellar dysfunction. We talked about people having this kind of broad-based gait so they can, by putting their legs out like that, they're trying to, balance and regain their stability. And it is very similar to what you will see with someone who's drunk and trying to walk, because it's affecting the same area of the brain that alcohol affects, the same area of the cerebellum. And we do also have 3 N's associated with a posterior circulation stroke. The first being nausea, another one numbness. Some patients may describe it as tingling, as well as nystagmus, which we saw very nicely on that HIDS exam. And this nystagmus may be horizontal, vertical nystagmus is very indicative, as well as rotary nystagmus. So that's kind of like a rotation of the eye. So in an effort to raise awareness, certainly trying to be out in the pre-hospital community and educate everybody here, but we've also been out in the community and educating, because we all know that getting the people in the community to recognize stroke is key to getting them rapid treatment. And it really does start with the people in the community, because they're the ones calling EMS. And that's exactly what we tell them to do, what we want them to do. One survey did demonstrate that 93% of participants could recognize unilateral weakness as a stroke symptom. However, only 38% could name all the other stroke symptoms that could occur, and then know that what they were supposed to do was call 911. And that's what we always tell everybody to do. Call 911. We emphasize the early activation, because we tell them that treatment starts when 911 gets there. So we do try to bring that to the forefront of their mind. But decreased public awareness of these posterior circulation symptoms definitely impacts the patient's outcome. So we began using BEFAST in 2012 in our emergency department to facilitate identification of those patients with posterior circulation symptoms, because we were struggling. We in the emergency department, trained staff members, nurses, doctors, etc., were missing these people. So we wanted to do something to try to really incorporate into an assessment, into the screening at the beginning, a screening for any patients that were coming in with potentially posterior circulation strokes.
Somebody's
And
asking,
I know that
somebody's
yeah, I'm
asking,
sorry, yes?
somebody's asking if you can discuss last known well times. I'm
Oh,
texting
absolutely.
them to see if there's anything in particular.
Okay, yeah, absolutely. I can start talking a little bit, and then you can always give me a little more information if I don't hit the mark. So last known well times, we always are asking people they like to report when, quote, they say when the stroke occurred, quote, when this happened. But what we really need to hear from them, and we do educate them on this, is we need to know when the person was last at their normal, at their baseline functioning. And sometimes that definitely takes a little digging. And we do really rely on EMS to get this information for us also. And I know it's included in your run sheets, is trying to find out when they were last known well, because as you know, a lot of people live independently as they get older, and they may not be out, in the community working. And it may be a day or two before someone speaks to them, talks to them, notices that they're not out collecting their mail, getting their paper, walking their dog, etc. And in those cases, we get the report that the person was found at 3 o'clock, but what we don't know is, okay, they were found at 3 down in their house with, left hemi paresis or loss of consciousness, etc. But what we don't know is when were they last normal. Certainly, we're still going to be doing the imaging to establish if we can see, is there a bleed in their brain? But if we don't have a last known well time, we are definitely not able to give alteplase or TPA. But we are, except I will give the caveat as to there are certain studies that are out there where, they may be doing some research and there's different imaging performed, as well as looking at timing, and that may be a little bit different. But for your average treatment, if without a last known well time, we are not able to give alteplase. However, with advanced imaging, depending on what we see and what we can find out, we may be able to take them for neurointervention. It just depends on, how long are we thinking they have been down. If, they've got rhabdo and they haven't been seen for a week, and looking at their imaging, we're going to look for any kind of, early infarct signs that may be able to tell us that this stroke has been going on, unfortunately, for a few days. I don't know if that in any way, go ahead.
Yeah, that was really good. So there was a follow-up question, says, I had a few patients recently who were at around 12 hours last known well time, and I took as a priority one to the hospital, but the hospitals didn't assess them like they do when I bring a patient in within 6 hours.
Okay, that's interesting because the criteria are, and not every facility does stroke neurointervention. However, if a facility is unable to do that, they should still be looking at the patient for eligibility. And I believe recent guidelines for even primary stroke centers were that people have to be able to get a CTA and CTP on these patients when necessary, so that images can be shared. We have, as you're aware probably, of the CRISP system, where hospitals are able to, as requested, look at patients' images at another hospital, so that we can then partner with them and then have the patient transferred to a facility that can do thrombectomy, can do neurorescue. So, as far as it's hard to say without knowing all the details of the person, but with a last known well of, generally our window is the 0 to 4.5 hours would be for TPA and or intervention. We certainly would take them to neurointervention also, but beyond 4.5 hours and up to 24 hours at our facility, they're eligible for neurointervention. Again, it will be based on their imaging and also comorbidity. I'm sorry?
The thrombectomy, even if the LAM score is less than 4?
Yes. So we still, LAM of 4 is your guideline to bring the patient. But remember, okay, and we're going to talk about this in just a second, LAM score isn't going to help us with a posterior circulation patient, right? There's no, think about your LAM score. And that's actually on here, your facial droop, arm drift, and grip strength. If you've got somebody who's ataxic, all right, so the ataxia, nausea, vomiting, they may not have these kind of anterior circulation symptoms. And that is why we are looking at these patients and why we have to do the specific imaging and evaluate them based on disability. Do not change. I am in no way telling you to change your protocols. I'm just raising the awareness and letting you know that we are looking at the patients when they are brought in, even if their LAMS isn't a 4, they could have a lower LAM score or a LAM score of 0 and still be eligible, as you will see in some of our case studies, for intervention. So I'm not sure if that helps to answer the question. Or
that's a great answer. It also speaks to why I think the protocol says, essentially all stroke patients are priority ones.
Yeah, and it does, it does lay out here that, if you have any of these indications, you're supposed to do the Cincinnati stroke scale and the posterior cerebellar assessment. So, it's definitely asking you to assess, but what I'm telling you is you're going to assess, but what you're going to find is it's going to come up as negative. it may come up as negative because the patient, again, depending on what you're going to find with them, they may have, let's say, balance, but their LAMS isn't going to be a score. You're not going to have a score for the LAMS score. So they're going to have a positive cerebellar assessment, but you're not going to get a LAMS score. Does that make sense? I hope.
Makes sense. Let's see what others say.
Yeah,
If
you'll
you have
get a LAMS
questions about
zero.
that,
I guess you'll get a
throw it
score.
in the
It'll just
chat.
be zero. Okay,
Yeah, that was a great explanation.
great. Thank you. Yeah, great questions, guys. Thank you. So in an effort to improve recognition of symptoms, that's why I'm here. We know that EMS recognition facilitates rapid treatment, rapid transport to the most appropriate facility, and then hopefully rapid treatment from then on out. What I just spoke about is really all on this slide. The pre-hospital tools lack sensitivity to posterior circulation symptoms. And there is a need for a rapid assessment that could be done in the field by EMS that really has to be, really short and sweet. And there have been studies done, again, very small, and I don't remember if it was Texas or California, but they had pre-hospital providers using the finger to nose assessment that I talked about earlier to identify ataxia. And they were able to show improvement in identification of posterior stroke symptoms from 46% to 74% after they used this finger to nose testing. But clearly, small amount of studies, there's definitely further research that's needed. And I'm hoping that this continues to be a high priority in the pre-hospital setting for finding tools that will help better identify these patients.
Can you clarify? Can you go back a second?
Sure. I'm sorry. Yes.
Confused. So finger to nose to identify ataxia. Ataxia is
right.
kind of walking, broad
Dysmetria.
gait.
Oh no. So ataxia. We were saying that ataxia kind of incorporates. It could be upper limbs or lower limbs. So, for instance, when you're using the NIH stroke scale, when you're testing for ataxia, you would be, for the lower limbs, you would take, for someone you can't stand up, you would have them run their heel up and down their shin and see if they could do it in a straight line or if they kind of have to wobble all over the place, which again would be used for someone who you can't actually stand up because it's unsafe to walk them. And then this ataxia, it's just another term for dysmetria, which would be like your upper limb testing of being uncoordinated. So lower limb incoordination, ataxia, broad-based gait. Upper limb incoordination would be dysmetria, inability to touch from the nose to the finger, and being inaccurate, unable to hit that point from one point to another point.
Excellent, thank you.
Did that help? Yeah, sorry if that was unclear, but yeah, it's kind of an interchangeable use of terminology in the effort to make it into a quote D, so you could have 5 Ds so people would remember. So, thank you for asking that. I'm sure there were other people that were unclear on that. So one final atypical stroke is in fact atypical because it is not an arterial territory. This is actually a venous territory and the venous system within the brain. These are your venous sinuses, and this is where blood drains from the brain through these venous sinuses. So a venous sinus thrombosis occurs when a blood clot forms in the brain's venous sinuses. This is rare, and there is a high mortality to it, as you'll understand why shortly. And in adults, there's about 5 in 1 million per year. And in those under 18 years of age, it's 3 in 300,000. This clot in the venous system prevents blood drainage. And what happens is, imagine like 695, if you've got all lanes blocked going one way, you're going to have this giant backup. That's kind of what happens in the venous system. You have this clot that eventually grows over time and just continues to propagate. And as it grows, it's starting to close off the drainage and blocks off that system, which then, as the pressure builds, can lead to rupture of the blood cells and then hemorrhage into the brain tissues. It does occur in both adults and children, and I do my best to avoid children. So I'll talk about them a little bit, but I don't treat them. So, you know, we're solely adults for what we're usually talking about. But for children, the greatest risk is within their first month of life. The risk factors, yes.
A lot of concern around that during early phases of COVID.
Yes, yes. Yeah, as you'll see, hypercoagulable states, clotting disorders, dehydration. Yeah, absolutely. You can see that there are similarities in both adults and children in clotting disorders as being a definite risk factor for this. But you'll notice that, as I said earlier, this is kind of weighted a little more heavily toward women, adults, because of the effect of pregnancy and the immediate postpartum weeks, as well as oral contraceptives. So again, your younger women that are going to be of childbearing age, that are going to potentially be taking oral contraceptives. They definitely mention that as part of the package inserts for hormone replacement therapy, as well as contraceptives, that they are possibly can cause blood clots. So you may see this in cancer patients, a higher incidence in those people who have inflammatory bowel disease, collagen diseases. So definitely, you know, a little, you know, weighted a little heavier for women because they are the ones that are taking contraceptives and getting pregnant and having children. As for children, again, the similarity with the clotting disorders, sickle cell anemia is always a problem with children, and strokes, as is heart disease and certain infections that can cause this venous sinus thrombosis, head injuries. And then for newborns, if their mother had an infection, and I don't know which ones it would be specifically, the child is at higher risk than for a cerebral venous sinus thrombosis. So the presenting symptoms, again, you know, looking at, you know, vague and really difficult to pinpoint symptoms that you will see with a cerebral venous thrombosis is a headache. That is the most common symptom. And the problem with that is, how many people have a headache? I mean, people get headaches all the time. And the reality is people don't rush to the emergency room, or we hope they don't, for just your generic headache. What typically happens in a lot of people with this condition is they have a headache, they put up with it for a while. Certainly if people have migraines, typically they will tell you that this headache is different than their normal headache. And people who have headaches all the time are very familiar with their type of headache and what brings it on and what it's like. So they put up with the headache for a bit, but then they at some point will seek medical attention, and it generally is an urgent care or a primary care provider. And when they go to these providers, typically antibiotics may be ordered, may be prescribed. It could be a suspicion of a sinus infection, you know, any number of things, sometimes new migraine, attributed to stress, etc. Lack of sleep. There's any number of reasons why they will kind of attribute this headache to something other than a venous sinus thrombosis. So patients will go home with antibiotics or, you know, other suggestions for how to deal with this headache. And what happens is symptoms progress to, they develop nausea, eventually seizures, severe focal deficits, and then eventually move on to lapse into coma. And then you may also see some less typical presentations. Again, nystagmus, if you catch them early enough, some dysphagia. They may have some cranial nerve abnormalities, but they may also have the cerebellar incoordination, depending on where in the sinus this backup is occurring. Now, imagine you're moving from headache to nausea, to seizures, to more severe focal deficits, and then coma. Anybody want to take a guess as to what's going on in their head and why this progression is as noted? If you want to stick it in the chat and then just give you a couple minutes and see what everybody's thinking.
While folks are putting in the chat to that good question, somebody asked onset range of time for CVT symptoms. So like, is this an insidious or daily?
No, it's not. Yeah, it happens over time. So that's where it starts with, yeah, you don't go from fine to comatose. This is where you could be going a week, 10 days, where over time you're starting with a headache and it gets a worsened headache, and you may take a little Tylenol, it may get a little better, but then it just never really goes away. It just, kind of continues on, and you're progressing with the symptoms, and you go from the headache, and then now you're starting with nausea also. Again, moving on, as time goes on, your symptoms are stacking, and you're having increased symptoms.
And folks replied that the increasing symptoms could be edema or increased intracranial pressure.
That's 100% correct. Thank you, everybody. That's exactly what's happening. So as that thrombus enlarges, it's causing venous congestion, leading to cerebral edema and increased ICP. This is where you're seeing the nausea, decreased level of consciousness, seizures, and when you've got complete obstruction, you're looking at herniation, right, and death. So really, the treatment, unfortunately, it's kind of medical management. You hope to catch people early. Generally, it's systemic anticoagulation with heparin. The heparin is meant to prevent further propagation of the clot. So you're trying to stop the process and stop the backup, but you aren't actually like having this heparin drip run, and that's going to just like clear up that clot. That clot has to just break down under the body's natural processes. And by preventing further propagation, though, if you're assuming there is blood flow, you're allowing that blood flow to continue while preventing any further growth of that clot. But you aren't just giving that heparin in the hopes that it's just going to break up that clot, because it doesn't work that way. You certainly are continuing with IV hydration, and if there's any infectious process that accompanies this, you'll be treating that. Obviously, if they're having seizures, you're going to give them medication for that to control those. Interventional radiology, I know a lot of people, think, oh, we'll just go in there and pull that clot out. However, it's really not that easy. There's a lot of risk involved, and I would say that when used, it's more of like a last resort. They definitely do try to do the medical management first, but knowing that this has a very, very bad outcome, there are, facilities that will try this as a last resort, but it's very clear that this is, really the only thing left. And this is something, we're trying because there's really nothing else to do. That's why getting in early gives you the greatest opportunity for a good outcome. So bearing that in mind, some prognosis indicators of poor prognosis would be, again, if there was deep sinus involvement instead of the more cortical area, if there was extension, into the cortical veins, that's not good. If you had coma as your presenting symptoms, so Talked to my daughter 3 days ago, haven't heard from her since. Tried visiting the house, couldn't get in. Finally get the police or fire department to break down the door, and they find her on the floor unconscious. Unfortunately, that's a really bad prognosis. And again, if it's been over 10 days that this person's been suffering with the symptoms, or there's been a rapid progression in their symptoms. So I do have some case presentations for you, and I'm hoping that this will help. These are all patients that arrived via EMS, and I'm hoping that this will help to just kind of shed some light on what you're seeing in the field, and then how we are reacting to that and treating that on our end when the patients come in, and hopefully speaking to not ignoring people that come in greater than 6 hours. So our first patient was a 93-year-old female who was found by family slumped over at the kitchen table about 15 or 20 minutes after they heard her up around in the kitchen making breakfast. When EMS arrived, she was on the floor and unconscious. This is taken from the run sheet, but alert to verbal stimuli. So she would not open her eyes or speak, but yet she would respond and squeeze a hand on command. She did have snoring respiration, so a nasal airway was inserted, and they noticed that her pupils were unequal, left pupil at 6 millimeters, right at 3, but both were reactive. She does have a past history of atrial fibrillation, stroke, and hypertension, and was currently taking Eliquis and metoprolol. The neuro exam documented was that she had aphasia, and but symmetric strength. So she must have had some, I don't know if she had drooling or she had some kind of way for them to tell that she had trouble swallowing, but also had, difficulty expressing herself. So you can see that her blood pressure is really within normal limits there. Upon arrival in the emergency department, she was met by the neurology team, and they noted a NIH stroke scale of 11 that was significant for her not answering either question correctly, forced eye deviation, so she did have now a gaze preference, partial hemianopia, a facial droop. So here we have visual changes here. They, she probably didn't blink to thread on one side, mild to moderate aphasia and dysarthria, and then extinction or inattention. So again, that goes back to her not, noticing things on one side. Her head CT was unremarkable, but there was a question, meaning there was no blood, but there was a question of a basilar clot. She was not a TPA candidate because she was actively taking her Eliquis, and her CTA did show a basilar thrombus with minimal flow to the bilateral PCAs. We did offer IR to the family, but they refused. They said based on her, what she looked like, we were very clear about what we thought was going on, what the natural trajectory of this kind of stroke would be. But again, when we offered IR, the family said, they didn't want to at her age. They just wanted to pursue hospice. They knew she would never want, a peg or feeding tube or anything. So they decided to pursue hospice. However, on the following day, her NIH stroke scale went from 11 to 7. And on hospital day 3, all she had was a facial droop and a little bit of slurred speech. All her extremities, she was anti-gravity, moving them spontaneously and to command. Her left pupil did remain large and unreactive, and she did have that left ptosis. So this patient spontaneously recanalized. Not something we see often. So the hospice referral was canceled, and she went to rehab. This was a great, certainly a great outcome, but they suspected that this was a cardioembolic source, knowing that she did have a history of AFib, and although she was on Eliquis, they would consider that like a failure of Eliquis. Now I know there's like blood tests I believe that they can do If one medication fails, so they can try other ones, but you know, that's something for them to deal with as secondary prevention. But she did end up going for slow-paced rehab. So that was a nice outcome for that patient, especially at 93 years of age. Our next patient, EMS was called for dizziness, nausea, and vomiting. And this was an 82-year-old male who had a sudden onset of this. Dizziness occurred when he was moving around. He denied, with EMS, he denied any blurry vision or headache. He told the pre-hospital providers that he had no medical history, was taking no meds. The wife thought he had a facial droop, but EMS did not note that on exam. They did do a full Cincinnati stroke scale and the LAMS, and everything was negative. He was, consult was provided, and it said, according to the run sheet, he was transported priority 3 with a consult. As they were taking him out of the ambulance, the facial droop came back, and they notified the nurse immediately. The nurse noted that the patient had an unsteady gait. He was unsteady on his feet when they walked him, and he did have a facial droop. According to the note, it did say that the ED doc did note that a BAT was called prior to arrival, so they must have called in, even though everything was negative, somehow communicated that their impression was this potentially could have been a stroke. So the neurohistory does mention that this patient had vascular risk factors, hyperlipidemia, and glaucoma with a baseline visual deficit. They did relay the information that you know, EMS had said when they picked him up, he could not stand or walk to the stretcher, and that the patient thought his speech was abnormal, but the neuro did not appreciate that. No dysphagia, or I'm sorry, no dysarthria or aphasia. Upon arrival, his NIH stroke scale was 1, and all he had was that partial hemianopia when he arrived, that baseline visual field deficit, which is from his glaucoma. Soon after, his NIH stroke scale went to 2 or 3 for the ataxia and the dysarthria. He did have that mild dysmetria on finger to nose in his left upper extremity, as well as we talked about that gait issue in the beginning. His head CT was negative for blood, so after a long conversation with the family, they finally agreed, and he was given TPA with a door-to-needle time of 71 minutes, delayed due to the discussion. So his head CT did demonstrate a hyperdense basilar artery. You can see that little dot right there. And this is his rapid imaging. So this is his perfusion scan. The CTA demonstrated the left vertebral and distal basilar occlusion. The CT perfusion shows no core. So if he had already dead tissue, it would have been pink, this color, or purple, right on the side of the brain. It does not show that. However, we do see decreased perfusion. That's the green here in the left cerebellum and PCA territories. So this is all brain at risk right here. And that is what we are trying to, you know, fortunately, nothing is dead yet, but that is what we're trying to salvage in our attempts at neurointervention. So based on that imaging, the decision was made to take him to the neurointerventional suite so he could have an angiogram, even though his NIH stroke scale was low, so never higher than a 3, right? During his stay in the emergency room, just the natural history of what will happen with somebody with a basilar clot, knowing that it's got a very high morbidity and mortality, we definitely wanted to go in and do that angiogram and get a good look at these vessels. As I spoke earlier about Dawn and Diffuse 3, those studies did not include basilar or vertebral arteries. So since then, there have been studies, most recently the Attention trial, and that looked at benefit of endovascular therapy in addition to best medical care over best medical care alone in those patients with basilar occlusion who present within 12 hours after the estimated time of occlusion. So, someone who has a very distinct onset, like this, who said, he suddenly developed dizziness. So they do the imaging, and based on this trial, our docs were saying this is someone we should be taking to the neurointerventional suite, doing the angiogram and seeing if if there is in fact a clot. So we'd already decided to take him to IR, and en route to IR, he had an acute change in exam. He became less responsive. When they asked him his age, he said, right now I'm 49, but he was 83. He became hypophonic. We mentioned that earlier as a symptom of posterior circulation. He had mumbling speech. It was just nonsensical and non-fluid. And then he had a right eye inward deviation. So just kind of looking in with his right eye and toward his nose. So there was discussion held with the providers, because remember, this patient, why would, we'll throw it out there this way, why would we potentially take this patient very quickly for a CAT scan, this particular patient, with this change in exam? If anybody has a thought on throwing that in the chat.
No takers on that one.
Okay, so we gave this patient TPA, right? So this patient having this acute change in exam, after we've given TPA, we're worried about a bleed. So there was discussion with the doctors as we were rolling through the hallway, and they just said, he's on his way to IR, get him to IR. We're just scanning him like right here. We're gonna look at him in IR. So by the time he arrived in IR, again, it's just a few minutes, but that quickly he had improved, was able to cross midline. He had increased responsiveness and was able to correctly state his birthday. So they just proceeded with the intervention, and then were able to do the angiogram. He was able to have a clot retrieval. So the clot in his basilar artery was removed. He had full reperfusion. We call that TICI-3. On hospital day number 1, his NIH stroke scale was 0. Now remember, again, it was only 1 to 3 to begin with, but he had no complaints. And the man on hospital day 2, who could not stand or walk to his stretcher, was now just ambulating independently in the hallway at his baseline. No needs whatsoever, no PT, no OT, just back to his baseline. From, definitely a disability. If he had been unable to walk and we had, been unable to remove that clot, the thought is certainly, like the other woman, maybe he would have spontaneously recanalized, but like other people, maybe he would have gone on to have a complete basilar occlusion and then gone on to die. But, we don't know. We just did what we thought was the right thing at the time. He was discharged to home and referred to cardiology. And in his cardiology appointment, he had an EKG in the office, which showed atrial fibrillation. Now, while he was in the hospital, he had all that done, but there was nothing captured. So they did, we have this like rapid follow-up for patients that are in the hospital. We call it a cardio neuro clinic, and they're quickly turned around and sent to this clinic so that they can evaluate them and put on sometimes extended long-term monitoring, like an event monitor, they call it, so that they can capture the frequency or existence of atrial fibrillation. So this patient, because he was in the office, was started on Eliquis since they knew already he had atrial fibrillation, but they put the event monitor on him anyway so that they could see how often he was going in and out of atrial fibrillation, and that way they could track that and then better manage his care. But totally independent, just back to his normal functioning, just with now adding Eliquis on board. This next patient was a 55-year-old male with a history of asthma and prostate cancer. He had recent placement of radiation seeds. And he called EMS because he felt like he was having a stroke. His last known well was 1 hour before he called EMS. He had had slurred speech, blurred vision in his left eye, right-sided weakness, numbness, and tingling. He was Cincinnati positive with a LAMS of 3 and was transported priority 1 to Sinai with a consult. He said he had developed this weakness and numbness while he was at the tire shop, so it all happened, very acutely. When he arrived in the emergency department, his NIH stroke scale was 5, significant for the facial droop, right upper extremity limb ataxia, mild to moderate sensory loss, and some mild to moderate dysarthria. His mother did mention that he had complained of neck pain 2 days prior, but it resolved. So after we cleared it with urology because of these his cancer and the radiation seeds, he received IV TPA with a door-to-needle time of 31 minutes. He did have a CTA that showed a right vertebral artery thrombus, so neuro-IR was activated. But once again, while awaiting IR, he decompensated. He developed the stagnus, a right gaze, drowsiness, and before he further decompensated, he had noted his right leg was feeling weak and tingling. So now we took him for a stat head CT, and again, we actually had not left the ER. We weren't on the way to IR yet, so we were right there, and we took him in for a stat head CT just to make sure. Again, we had just given him TPA that he wasn't bleeding. So after the CT scan, he decompensated further. He became lethargic. He was no longer protecting his airway. So anesthesia responded and intubated him, and he was taken directly to the IR suite after intubation. Where in the IR suite, he was found to have a right distal vertebral artery and basilar occlusion. So once again, we had a successful thrombectomy with complete revascularization. He did have an NIH stroke scale of 3 on post-op day 1 with just facial droop, dysarthria, and limb ataxia. And then he was discharged home on day 3 with an NIH stroke scale of 0. His MRI did show some small infarcts in the medulla and the bilateral cerebellar area, but he's, functionally independent and back at home.
Linda, what was his last known well time on that last case?
It was 1 hour prior to EMS arrival.
Got it. So well within the
so rapid. Say it again.
Well within the 4.5 hour window.
Oh yes, absolutely. He was, as well as the one prior. They were both, because they both received TPA. So they were both well within the time, and again, rapid treatment. You're looking at better outcomes. That's why the whole, everything is in place to be able to get to people as quick as possible. So yeah, very well done. You can just imagine, look at how he decompensated within our facility. Imagine if he had waited to call 911. He was at the tire place. So hopefully someone would have noticed him collapsing, but, fairly rapidly.
Yeah, I guess
right?
I wonder, how the hospital deals with the situation where, somebody may have some kind of lingering symptoms for more than 4.5 hours, but then they develop an acute decompensation.
Yep.
That is identified within 4.5 hours, but technically the overall syndrome started well past 4.5 hours. So you still may TPA them.
Yeah. So so the clock never restarts if they do not go back to baseline, and he never was 0. So the clock didn't restart on him. And remember, we gave him TPA even with a low, like a 1, in fact, a 0 NIH stroke scale. If you're disabled from, you're going to be disabled because, say, you're aphasic. So you could have a very low NIH stroke scale. It could be, a 2. But being aphasic is disabling. We're still going to give you TPA. We're still going to treat you. Now, there's probably not going to be a clot for us to go after with an NIH stroke scale of 2. However, not for aphasia, but with this patient, a low NIH stroke scale, but clearly disabled, we gave him the TPA very quickly. It was like 31 minutes, but he then went even to progress beyond that time. So he definitely had the TPA well within the time frame when he was actually less disabled.
Thanks.
This patient, a little is another scenario, but is I brought it here because it was kind of a good catch on the part of EMS providers and followed our protocol to a T. He was leaving church and he just sideswiped a car on the way down the street. Patient found him in the car, belted, with a facial droop and called 911. And when EMS arrived, they assessed the patient, noticed the facial droop, slurred speech, fixed gaze to the right, left-sided weakness, and left neglect. So they documented a LAMS of 5, diverted the patient from St. Joe's to us, and then did collect a past medical history of the patient having AFib, but was not on anticoagulation. So, capturing this, certainly he did have the symptoms when he was examined, but probably the field, the gaze problem is what had him sideswipe the car as he was driving, because he had that neglect.
And
When
that's
he
pretty
arrived to
common
us-
for back one
Yeah,
second. That's pretty common for that presentation where the eyes are looking at the lesion, right? Looking at the side of the lesion.
Yes,
And
exactly.
all the
Look
symptoms
to
are
the-
contralateral.
That is right. Yeah, and thank you for bringing that up. Yeah, that is common. It's with a stroke, we say it's look to the lesion. So I can go back to him, right? So you have a fixed gaze to the right. So he's gazing to the right because the lesion is on the right, and he has left-sided weakness because weakness is on the opposite side. And then he has left neglect because he is gazing to the right, so he is neglecting the left side. So that is exactly how it works for stroke. You look to the lesion, and in seizures, it's away from the irritative focus. But we just remember stroke is look to the lesion. So this patient, his hospital course, upon arrival, he had an NIH stroke scale of 17. His last known well to arrival was 89 minutes, and his door to needle was 23 minutes. So he received TPA. He did go to IR for a right M1 occlusion, and his door to revascularization was 97 minutes. He was discharged home the following day, fully independent. NIH stroke scale of 0. He's now taking an anticoagulant for the AFib that he didn't take it for before. But again, good catch with the side swiping. This patient was a 74-year-old female found on the bathroom floor by her husband. She was not responding, just mumbling, and he placed her in a chair with great difficulty and called 911. She'd had a recent ACDF, so anterior fusion, and a spinal stimulator placed. She had been to the ED 1 week prior for migraine. Imaging was done, it was unremarkable, but she continued to have headaches over the past week, so in clusters. She had been in her normal state of health the night before he found her when she went to bed. So EMS was dispatched for stroke. Their exam noted that she responded to painful stimuli with eye opening. She was nonverbal, she was not following commands, and she had pinpoint pupils. Now, because she had been taking pain medication because of her recent surgery, Narcan was given, and she then did respond a little bit to verbal stimuli, but their consult was placed and she was transported to Sinai. Upon arrival in the ED, her systolic blood pressure was 200 and it normally ran 140 to 150. She was, as we had mentioned previously, seen in the ED 1 week prior for a frontal headache, but had a negative head CT. The headache with nausea improved during the week, but it never fully resolved. And her NIH stroke scale was now 29. You can see from the head CT, she had a large left hemisphere intercerebral hemorrhage. And this had about 8 to 9 millimeters of midline shift. But this really is not a typical location for a hypertensive hemorrhage. And, and again, she normally runs 140 to 150 with just 200 here today. So they did do further imaging, and the CTA showed a left transverse sinus, cerebral venous sinus thrombosis. She was admitted to the ICU. They managed her blood pressure with Clevaprex. The hemorrhage remained stable, but there was now more edema and an increased shift up to 14 millimeters. So that did worsen. She was taken to the OR for a hemicraniectomy on hospital day 2. And there was improvement radiographically, but not clinically. So the family decided to make her comfort measures only on hospital day 5. So that, again, a venous sinus thrombosis, unfortunately, was not a good outcome. So that is the end of my presentation. If anybody has any questions, I'd be happy to answer them.
That was a great presentation with a ton of great, case series, and it was great. Fantastic, somebody says. Great.
Oh, thank you very much.
Somebody brought up a question: at what point should we start thinking about temperature and possible meningitis? I think it was within the context of the last patient who presented with altered mental status.
Okay.
Yeah,
I don't know. I'm sorry, say it again.
I don't know if
Go
you
back
want
to
to
that
tackle
one.
that.
Oh, so I don't know. I mean, I don't know what your protocols are as far as temperature. This, I think when you're looking at a patient like this, sudden, sudden onset of basically unconsciousness, had not been, quote, sick other than having headaches, over the past week, headaches and nausea, but really migrainous type stuff with, the stiff neck. This was not a young person. This was, I believe she was kind of thinking in her 60s, early 60s, basically in her normal state of health the night before. So not really a progression of illness, fever, malaise over time. And I'm not too sure, you would know better than I about your protocols for taking temperatures. Is that something you regularly do for patients?
Well, yeah, I would reframe it, and I would just say that, I think that sepsis is clearly in the differential for anyone with altered mental status, right?
Oh,
So
sure.
you mentioned certainly kind of the timing of the onset, fevers, cool and clammy skin versus warm and dry. Like this patient probably was pretty warm and dry, is my guess.
Yeah. No mention whatsoever. Yeah, no mention anywhere of anything about that. So certainly, there are a lot of, things on your differential for sure. And sepsis would not be off the mark. She did have a procedure, so, but she'd also been to the ED within a week with her headaches. So, again, all of those things may be on your differential. It's just really responding to what you're seeing. You could see that this patient being unconscious, this was an emergency. She was taken priority 1. So, I think perfectly reasonable response to what you were seeing, in a patient with, pinpoint pupils, got the Narcan. I mean, all good things.
Good. Well, we're definitely going to hang around if other people have chats, but I do want to close out the recording. And before I can do that, Linda, I have to thank you for being here, for sharing such amazing stories, and just for your dedication to this work. This is obviously an incredibly important point. And I think that oftentimes there's a lot of confusion in the field, and I certainly think there are always opportunities for all of us to learn yet something a little bit new. So for that, we are super thankful.
Oh, and thank you. And I'm thankful for what all of you do every day, and you know, in the challenging situations that you have faced, especially over the last few years. You are our front line, and we really do you know, depend upon your assessments, your skill. And we see every day you making the difference in people's lives, and you know, really, you know, they have a good outcome because of everybody here on this call, and you know, being available and taking your time out of your evening to come and listen to this talk. I really do appreciate it, and thank you so much for everything you're doing.
Well said. Thank you.